Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. We are at the 159th episode. It is November 3rd. It is election day, and so make sure you get out and vote as I did. Only your voice can make it happen in your vote. So today I'm going to get back to my specialty spotlight coding, and I'm going to focus on orthopedics and really focus on some fundamentals of fracture coding. So fracture care services and just the basics, because I think some practices may miss the mark a little bit when trying to make a decision for reporting fracture care services. And so I just want to kind of bring into light what, from an auditing perspective, payers are looking at. And also I noticed that on fracture care, a lot of line items tend to get denied, and we want to make sure that we are not falling into those denial traps. So we want to move forward with that. Also, the Codecast today is brought to you by Modern Healthcare, the only healthcare business news weekly, online, or white paper magazine, modernhealthcare.com. Okay, so let's take a look at fracture care just for a little bit here. So we know fracture care codes, which means that those are the codes in the surgery section in the 20,000 code series. They have a 90-day global package, meaning that any kind of E&M or evaluation and manager visit code prior to the fracture care is going to need a modifier, and then you will not be able to bill for any kind of related services in the interim during that 90 days with the same diagnosis. And then in the after effect, you'd have to wait till after the 90 days to be able to get more services or procedures performed, which also may play into your thinking as far as how to bill for services. The biggest thing, though, is also intent and how did the patient present to your practice or present to your office. So I'm going to speak to in-office fracture care coding, and there's a couple of positions or options when it comes to billing for these services, and how the patient presents themselves to your office will help you make that coding decision. So let's say in scenario number one, we know at sign-in that the patient has a fracture in his left wrist and only a brief history was taken, and they come in with an x-ray from the ER or primary care office, and they basically have transferred the patient over to you for fracture care, and I'm doing my air quotes. So what that is, and the x-ray says that it's a closed fracture. And so a lot of times the orthopedic practice will take another x-ray, which I'm surprised that payers haven't caught up with this. If the patient comes in with an x-ray that you can use, then there's really no reason for another x-ray. But I know a lot of practices do that because they want their own. But for me as an auditor, I actually question it and say, why are you taking another one? That's duplicative services and not necessary. But let's just say that, the patient does come in with that film and you end up taking another one. So you would have an A to P and lateral, let's say 73-100. You would have a code from the M section of ICD-10 starting at M25.532, depending on where the injury basically or wrist pain is where they would come in with. And then the fracture care. So there's with and without manipulation, meaning did the physician have to do anything to basically jar it back into place? And if there's no manipulation, then you're looking at 25,600 for that service. And again, that does come with global days. And some of you that don't code for surgery may not be familiar with global days. And again, what that is basically there's a global day package put onto certain surgery codes saying that there's an assumption that the patient will be seen for a related service prior to the treatment, and they will be seen at least once or twice during that 90-day period, and the global days are 0, 10, and 90, to be able to get a follow-up visit. And the work value and the cost, I should say, everything that goes into that the RVU, so that relative value unit, includes that E&M portion, if you will, that evaluation of them returning to the clinic, because they know it's routine. They do return because you did surgery, you want to see what's going on. Now, what's interesting about the fracture care codes is that they are under surgery musculoskeletal system, but they're not necessarily what the patient would look at as surgery. So that's where sometimes the mindset, when the patient gets the explanation of benefits, it'll come up as, closed treatment or surgery wrist. And what the 25600 actually says is closed treatment of distal radius fracture, Sakakali's fracture, or esophageal separation includes closed treatment of fracture of ulnar styloid when performed without manipulation. So the doctor didn't have to jar it. Basically what they do is they feel around, they make sure everything's okay based on the x-ray, and then they put it usually in a cast or in some kind of a support. And then that's 25600. And your diagnosis code for that now moves into the fracture information. So now that's around the S52.531A, and then you need an extra digit there to reflect on the encounter. Then sometimes a post-reduction film is also taken, and that can be billed just to make sure that it's set right. Typically, you'll get those paid if it's with manipulation. So for example, if it was with manipulation, the code would be 25605, so it'd be 25605. And again, with manipulation would mean to jar it into place. Now that's if you bill it with the global package. So no materials can be billed with fracture care for Medicare. Some of your private payers may allow it, but Medicare says no. So you have to keep that in mind. And then if the patient's coming in undiagnosed, so this is the second part of that. So a new patient may be billed on the initial encounter with global fracture care codes as long as the patient presents to the clinic undiagnosed and you have support of a complete E&M. You would need a 57, not 25 modifier, because of the 90 days, you would have to show decision for surgery. This is a surgery code. And without the modifier, it would be bundled. But that's not to be considered routine. If the patient already has a referral that says that they are fracture and they're coming to you for fracture care, there is no E&M component. And the reason is that medical decision-making was already made by the first provider. So be cautioned with that. In my auditing, I take back a lot of E&M services when this is done incorrectly. Now, that is for billing for the global. Now, let's say that your patient presents to your office, and this would be scenario 2. They're self-referred with severe left wrist pain. So we have, again, our M25.532. Let's say it was due to an accident or they fell from a ladder at home. Well, we do not know the patient if they have a fracture until after we actually do an exam and an x-ray. And all the E&M guidelines have to be met to be able to figure out what's going on. So let's say they were met and you took an x-ray and then there was a cast application, a re-x-ray, and you also get materials. So typically that would be, if without any risk factors or anything extra, it would be a level 3 new patient visit, 99203. Because we're not going to be billing fracture care code, we're going to be billing more line item application, we would have a 25 modifier. Then the first x-ray, 73100, again, A to P and lateral wrist x-ray. This would be, again, with the M25. This would be the pain codes. And then the cast application, because we took the x-ray, now it determined that there was an actual fracture. We would have our S52.531A. And then a re-x-ray, possibly 73100 with a 76 modifier, not 59. We're repeating a procedure. And then your materials. So you may have the A4580, A4590, and for Medicare, they're Q codes in the range of Q4001 to Q4051, depending on your casting and splinting supplies. But just make sure that you are also looking in CPT 2020 for instructions. It talks to you about initial immobilization of the splint cast retraction device is included in surgical fracture care codes. Subsequent cast applications and supplies. So let's say the cast gets wet and the patient comes back in to get that changed out. That is billable, regardless if you're in the global days or not. But any office visits, if you're doing the global service, would not be billed. If you did the cast application, you would get to have an office visit when they come back in. And then report the initial casting in addition to the E&M service when no other surgical treatment is provided. So that you have to know that there's rules there when it comes to when you can code for it. Now, let's say the patient was in a cast from the ER and then they come to your office. So can you code a cast removal, which starts with the 29700 codes? Yes, you can, as long as you are not the physician that put the patient in the cast. So if the cast was applied by another physician, yes, you can code for that. So there are rules on fracture care. You have options on fracture care. And so you can bill it as a global service. You can, because you know the RVUs are going to be higher, but you're going to deal with patients because now it's not about a copay, it's about their share of cost or 20%. Or you can bill it as an itemization in the office if you didn't do manipulation. Once you do manipulation, especially Blue Cross Blue Shield, it's no longer considered basically line item service. It's now considered the global service. But if it's just closed treatment without manipulation, you have options. Now, how do you determine this before you throw it on the claim form? Well, the big thing for me is I would have the physician with a mindset saying, how many times is the patient going to come back? If the patient's going to come back more than twice, then you're going to want to line item it out because each office visit you would get to code for. And in the long run, that would be more profitable and you have the option. If the patient's going to come back once or twice, then it may be more appropriate to bill for the global service. Now, again, it's up to your practice, up to what you want to do, but you have to also look at your payers because some payers see a fracture diagnosis and they immediately want the global service as well. But as a rule, and I always usually talk to Medicare, you have an option when it's a non-displaced fracture or non-manipulated fracture to bill it either with the global services or as a line item with the office visit, the x-ray, the cast application materials. So remember, when you bill for the global, you don't get the cast application materials and you may not get an office visit if the patient was transferred for fracture care. Because what the plan is to do fracture care, especially if it's a new patient. It's not that you're evaluating them to see what you need to do. You're basically taking the patient in and doing what the referral was for. So it has to be medically necessary to be able to bill for that E&M. And a lot of times with referred fracture care patients, it isn't. So that mindset is really what you have to think about when you're billing for any kind of fracture care services. And I know it can be a little confusing, but if you keep those two things in mind, basically how many times is the patient going to return, and then how were they referred or how did they present? And that should let you kind of know which way to go with that and hopefully help you as well. And, sometimes the patients, based on cost too, we don't want to bill based on that, but they appreciate when you do a line item because now you can spell it out. You had a visit, an encounter, you had an x-ray, you had a cast application, you had a re-x-ray and materials. So sometimes just from a statement from the patient, not getting them to call you, it can be helpful to itemize it out. But this isn't to take away that there are times when a patient does come in, I always think of pediatrics, where, you kind of have to, restraint a child a little bit and it gets tough and you deserve your global services. But the patients will have an out-of-pocket that's a little higher and you may get patients complaining because they're going to say you didn't do surgery when their EOB says, yes, you did. So just know that you do have options and I would really take a look at those options. One of the things I wanted to also bring up when I talked about x-rays, and especially retaking them, remember that when you take an x-ray in your office, you want to make sure that you have a report. It has to be separate from your E&M service where it just has an entry that says, x-rays taken. But it has to have a report, just like an interpretive report if they had them done at an imaging center or hospital. Should have when and where the x-rays are taken, what views in anatomy was visualized, what did you see on the film, and then what the impression was. Remember, when you are billing for a global service of an x-ray, you're saying that not only did you own the equipment and you have the technical portion, but that you also are doing a formal interpretation, which is a report. And that's part of CPT guidelines under radiology. You have to have a formal, it even quotes it out, a written report signed by the interpreting physician should be considered an integral part of the radiological procedure or interpretation. So you can't just have it in the E&M. It needs to also be in there if you're using it for medical decision making, but you also need to have a separate report that reflects that you can support that global service. Okay, so just keep that in mind if you're an office or a practice that bills for x-rays. Okay, so let's take a look at our coding question this week, and actually it sticks with the specialty highlight of orthopedic. And actually, I'm going to disagree with something I saw on an orthopedic coding alert. And this was an audit I did for Blue Cross Blue Shield of Michigan. And I saw this in the alert and I went, oh, no. So here was the question. It says, in which situations would a coder need to use Modifier 24 on an E&M service? And the respondent said coders need to use 24 when a patient is seen during a post-op period for a service that's unrelated to the surgery. I agree with that. But the person went on to say, anytime an E&M service unrelated to the surgery itself occurs during the global period, the modifier 24 would be appropriate and required. I agree with that. But the example that they gave is they talked about a patient with bilateral carpal tunnel syndrome. They said if one side is worse than the other, the surgery on the worst side might happen first and the evaluation of the other side would happen second. And they're saying you can bill an E&M service during the global period of the second one and then put a 25. I totally disagree. The problem is because at the initial exam, you basically said the patient has bilateral carpal tunnel and probably related to the fact of which side was worse, which we will handle first. And most physicians do not do bilateral carpal tunnel anymore. It's first of all, it's mean just for hygiene purposes, but it's just wrong. So, and a lot of times it is too restricting to patients. So, that would not be the case. Well, let's take that same scenario and let's say that they did a right carpal tunnel and then the patient came back in 6 weeks later and the patient said, my left shoulder has really been bothering me. And I don't know if it's for overcompensating from, having the cast or the splint on the right side, but can you basically evaluate my shoulder and see if I have more issues that are unrelated to the carpal tunnel? And the doctor does a full exam and history and makes a decision of what they're going to do, maybe injections or to even leave it for the next time. That is a 24 modifier for sure. So it's unrelated to the surgery, and you have to be careful about what is considered unrelated, because the 24 modifier, that is the number one RAC audit misstep. So that is audited all the time. Number two has to do with how you use mid-level providers. But it's crazy how the 24 modifier is used inappropriately, and doctors are being overpaid for services because they're using that. And then the services end up having to be refunded, and now you have a black mark on your record, and now you're looked at more often. So make sure you understand that 24 means completely different, not something that your physician has decided to wait on a bilateral procedure just to do it later. They already know about it, so it is related because it's related to an encounter and it's related to the cause and effect of that already diagnosed problem. So really read between the lines on some of that and be clear on what is unrelated to use that 24 modifier later on. Our coding question is brought to you today by Pure Leaf Real Brew Tea. Real tea done right, pureleaf.com. Okay, so my personal tidbit this week, some positives and some sad news. So first of all, my Steelers are 6-0, yay. So I'm happy, but this weekend, or I should say this past weekend when you're hearing this, we play the Ravens, which are our rivals in our division, so the Baltimore Ravens. So I hope we're going to continue as the only undefeated team in the NFL, but that's been a real glimmer of light in my world because I'm working so much and some things have been happening that have been a little sad. We had our cat of 19 years, TJ, pass away last week, which, it's going to make me tear up. Sweet little kitty. But he just couldn't take it anymore. And he actually was well right up until the end. And he moved with my daughter to Arizona. And so her little buddy, her friend that she really had with her, she had to deal with that. So I feel really, really sad about that for her. Also, my 91-year-old father-in-law, who I had mentioned in the podcast before when it came to Hodgkin's lymphoma and missing it on telehealth and all that, he did pass away last weekend. So it's been a rough week in our household. But I posted something to Instagram, just, in remembrance of some people. And thank you for everyone for the sweet prayers and the comments to my Instagram story. And just, really just those heartfelt comments. I really appreciate that. When we are in the digital age and we get that outpouring of just concern and compassion, it just makes me happy that I know that I've got some great people. Kathleen, thank you. April, Ruth, as always, Monica, Julie, Maureen, all you guys, just Denise, you just really made me happy with, and Claire and Sarah. So thank you very much for just the kind words. I really, really appreciate that. But also another positive was I had my podcast brunch meeting this past week, and I really liked the topic. So my podcast brunch club meeting means that, and I mentioned this before, it's like a book club for podcasters. And our topic was uncertainty. So they give us a playlist that we have to listen to. They give us a whole month to listen to it. It's amazing how quickly that date comes up on you. And then we all meet at a certain time. Unfortunately, because we have people from all over the world, my time is 6 a.m. the last Saturday of the month. Oh my gosh. So I have to set my alarm for 5:45 a.m. so I can get up, brush my teeth, turn on my coffee, and pull my hair up and get on my laptop. But uncertainty was the topic. And it was basically how to handle things that are out of your control. And, I really thought it was an interesting topic, and just a couple of tidbits that I thought would be helpful, especially with what we're dealing with right now in the world, not just between the election year, but the pandemic and just the unrest and just everything just seems to be spinning. If there's one thing, that emotion that is stronger than the fear of uncertainty, it's the hope for the future. So everyone out there, if you're struggling right now, just keep focusing on hope, believing that, and you will win. So try to not live in your fears, live in the hope for the future, and you will win. We will all win. So until next week, everyone, on this Terry Tuesday, thank you for spending some time with me. Make it a great day and a great week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.